I'll just give you a bit of background. So my name's Steve Alder. I'm a neurologist. Some of you will have heard how I ended up getting into kind of improvement, management, and leadership. And so, what my position is around the NHS at the moment is we're in a very bad place. And in the last year, I did this executive fast track program, so I got the opportunity to see the great and the good of the NHS. And nothing that I saw in that year filled me with much hope, to be honest. But there is kind of hope. But in order to kind of liberate that, we need to go right back. And what is missing for me is kind of, what is the diagnosis? Well, what's the primary challenge the NHS has? Number one, what's the diagnosis? What's the solution/treatment? And so I did have some slides that talk about that, but it just eats into too much of the time, and I want to concentrate on the hopeful message of the example. So the primary problem the NHS faces is just one word: it's productivity. The challenge is, can we make it better and can we make it cheaper? That's the challenge. So the diagnosis is recurrent failure to become more productive. So the solution to productivity has got nothing to do with healthcare as such. It's kind of what do we know about what makes entities productive, and what do we know about what makes healthcare entities productive? And the good news is exactly the same. So there are 7 characteristics of productive organisations or systems. Number 1 is that their leadership teams are enabling. They understand in this world of ours, particularly healthcare, that the expertise lies in the people at the front line who deliver the care. Number 2 is any middle management structure strives to create alignment inside the organisation, along patient flows, and between organisations. And they have a philosophy of coaching. It does rather kind of require that you know something to coach, but that's by the way. Then number 3, which is really important, is that the area of focus is the frontline clinical team. That is where the organisation puts most of its energy, on frontline teams. So as a consequence, that drives 4 other things. A massive emphasis on high quality frontline leadership. They're considered to be like the key roles. The next thing is that they have an improvement methodology. And that improvement methodology totally integrates day-to-day management and improvement. You don't have an improvement function and you integrate the two together. And in order to make that work, you need 2 other things. You need bespoke data that the frontline team say they need to improve. And then they need bespoke support. So support to help embed insights from the data. And if you go to the Mayo Clinic, they have 300 computer engineers who work with frontline teams to embed local data systems, and have 500 what they call diffusionists, which when you come up with an idea, they help you turn it into reality, and if it works, they spread it across the organisation. So that's, now the problem for the NHS is we've got 0 out of 7 of those. Okay, and that's not surprising given where healthcare is in the maturity of it as a sector and the complexity of the value proposition of health. It's just complicated. You know, building a plane is complicated, but this is complex. So that's why everyone's struggling. So the number of organisations across the globe that are really getting their hands around this is small, but the good news is it's incredibly consistent. So, so what I want to talk about today is a method, the improvement method. Okay, I could give you a talk about enabling leadership teams or aligning middle managers or frontline leadership. Fascinating as they are, not for today. Today is how to think about this improvement method that allows you to integrate day-to-day management and find the opportunity. Because in the end of the day, we have to find this way. You know, if you're going to find this 22 billion, you have to be able to look frontline teams in the eye and say, this is where it is, and this is how you are going to help, how we're going to help one another to extract it. So, and the best way I found to explain that is just to give you an example. Okay. So I've now done 25 projects using this method. The analysis always shows the benefit. Whether or not the benefit gets realised in reality is all to do with those other factors. Where they all line up, it comes out. Where they don't, it doesn't. I'm getting better and better at kind of aligning them, but you know, it's that top layer is still pretty tricky. So this is the stroke example, which is probably about number 13, but the good news about it is that I captured all the information all the way through, so it's totally complete. So we started off as 2008 with high mortality, high cost, poor patient experience. I'm just going to go back slightly. And so typically what would happen is that, so this was the neurology department, and I took this from the board papers, and that's how many metrics there are relating to our department on the, and of course what happens is, so stroke is here, number 9, so now we've got some stroke targets on the board. They're on the monitor risk rating scale, so really important. So typically what happens is that everyone just focuses in on that, excluding everything else. There's no holistic sense of how any of this kind of fits together. And of course, you can try and fix it one thing at a time, but you just run out of money very quickly. So you have to try and have a more intelligent way of doing it. And this is kind of how you can do this. So step number 1, there are 6 steps, is you just stand right back and you look at what you're dealing with. So you will have in all of your clinical departments activity. You have clinical activity, clinicians running around seeing patients. You have support, people running around helping them try and do that. Sometimes helping, sometimes not. And then you have cost. You have cost of the clinical work, and you have cost of the support work. And on top of that, someone says, you've got to become more productive. So what happens, consciously, unconsciously, a mixture of both, is that people chip away at the support, desperately hoping the clinical work doesn't fall over. It doesn't immediately, but it does eventually. So it's, QUIP came along, pay freeze, tariff deflation, seemed to kind of work okay for a bit, then suddenly bang, financial collapse. So that's not. So what we're going to do now is slightly different. Is we're going to look at the clinical work first, and we're going to analyse clinical work from a value perspective. We're going to redesign around that, and then we're going to put appropriate support around that clinical redesign. And it may be that the proportion of support to make it work goes up, but the total cost will come down. And now this is a big, big leap of faith, isn't it? Someone has said this to me in 2002, and I said, my God, you are taking something good. This cannot be true. So I'll take you through it step by step. So the first thing, the next thing, so step 2 is you've got to have the right model in your mind. So this is like a local healthcare system. We have our friendly regulators, we have our friendly system architects, otherwise known as commissioners. And we have the real people we need, the patients, and they're going to go through the system, and they're going to try and extract value from providers who live in those types of entities. And you have frontline individuals, teams, managers, and middle management. And then depending on how you define your system, you may need to pull on mental health, social care, economics, teaching, training, research. So that's kind of the model I use to sort of orientate myself. Then so the patients are not randomly appearing. They have a medical condition or a clinical condition that's making them put their hand up to sort of say, help me please. So step number 1, given the type of clinical problem that you're trying to deal with, how do they get into this system? So in this is stroke. So most people who have a stroke have their stroke as they're wandering around, they're in primary care, bang, they have a stroke, and they come in an ambulance to the hospital. That's how the vast majority of people have their stroke. Now, as we're aging, there are increasing numbers of people who've got other problems who then come in, but it's still, that's the majority. And so you start off by studying the demand, and that will always show you this, which is unbelievably predictable, consistent demand. healthcare is spookily predictable. Now we are starting to see some increases in demanding conditions, but it's very small, less than 1% a year. It's incredibly predictable. No one is surprising us with new conditions. I mean, I can tell you how many people will be, whatever time it is, 3:30 on a Monday afternoon at Plymouth. I can tell you almost to like one or two how many people have come in so far today, what conditions they'll have had. But of course, the system reacts like, whoa, patient has appeared. We better react, as if it's a new thing. So the problems are in the design of how we respond. And so what you're then interested in is what, after they've arrived, what is the consumption streams fall out of coming into the hospital. Now, this is important. So this is what you find in a hospital. You'll have slightly different things depending on what the conditions you're looking at. But basically what you find in a hospital for any medical condition is that you can split the patients by length of stay, incredibly predictable proportions. But this is what you find. So in stroke, it was a third. 84% of all the cost to the service was coming from that group of patients, long-stay patients. So, now this is important so that if your challenge is to make it better and cheaper, this is a logical place to start. I am not saying there is not improvement opportunity in these two streams, but if you go for that first, this will just eat up any improvement you make. So this is the logical place to start. Now, just because it's high consumption does not mean necessarily it's poor quality. It just means it's expensive. It could be totally fantastic care. In fact, it might need to be more expensive. We just don't know. So the way to know is to do this. So you get your consumption stream, and then you take a random sample of case notes from that consumption stream. And you get this grid. And for each case note, you write down what they presented with, what they were like before the stroke physically, mental health, social care. And then for each of the patients, you write in, was the diagnosis timely? Was the treatment timely? Did they get complications? Was the discharge timely? Effective, safe, and patient-centred. And you can either you can try and fill out the grid before you start doing the case note review, or you can adapt what you think is good or bad as you're going along. But just the process makes you think. Because it's like, if I said to you, for a stroke patient, what would be an optimum time to diagnosis? What would you say?
Less than 3 hours.
Less than 3 hours?
You're asking us to stroke patient?
Yeah. Okay, so, and now, and 24 hours a day, 7 days a week? Or actually, so 4 hour target, everybody knows about it. Doesn't seem so outrageous at all, does it? So I found doing this really, really kind of opened my eyes to some of the rubbish I found myself saying. But once you fill that in, you can then say, okay, we now know that this stream of patients was expensive. We now have a much, much more empirical assessment of the quality of the care. Because when I kind of think about myself, I'm talking in front of somebody other than the board who actually respected and said, do I provide high quality care? What I'd like to be able to say is I set myself standards in here, and we monitor them all the time, and this is how well we do. That would be high quality care. And how many of us, for how many conditions, can say that? None of us. But all doctors say, I provide brilliant care. You think you'd like to provide brilliant care. And it's tricky. So we've got to try and move into a more sort of empirical space. So what did we find? It was really, really interesting. So we found that 53% of the stroke patients before the stroke were really frail. Okay, they did have a new index stroke, totally legitimate, but they were frail. We then found that splitting the patients by severity of stroke helped, and that allowed us to see that there was basically 6 substreams: frail, well, mild, moderate and severe. Why was that important? Because we found that 75% of all of the consumption was coming from patients who were frail and severe. And what do you think they scored on their grid? 0 out of 16. We didn't even really know what to put in the grid. But basically, these patients were all dying on the ward in about 40 days. Unstructured, inhumane, overtreated, complete confusion about whether or not we should be feeding them. And with these patients, what we realised, because we hadn't appreciated how frail the patients were, none of the policies took into account your degree of frailty. So, helpful analysis. So that what we then did was using this thing to guide us. We sort of said, okay, so we now know the segment of all the patients that's problematic. Where did we discover them at morning handover? What's the relationship we have with them? Very, very intimate. This is people dying. What should we be doing? So the team went away and kind of said, well, we can't provide you a protocol, but we can actually provide some options for patients. And so we ended up with full care, palliative care, something in the middle, which we called expectant care, and every day the patients and the family were reviewed. And obviously inevitably they went on to palliative care after a few days. What do we need? That's the protocol. We've actually got everybody we need. We need a little bit of oversight from the medical care pathway guys and the hospice. And it turns out that it provides, much better care and it's much, much cheaper. So what happened as a consequence? So this is just from this one stream of patients. The time for the unit dropped from 2 days to half a day. The length of stay dropped from 15 to 8. And the proportion of people spending 90% of the stay went from 22% to 80%. And every measure, because we had developed measures from our grid, went up as well.
But why is the last slide a good thing?
So this is percentage of patients spending at least 90% of their time on the stroke unit.
Okay.
So here they were on
so rather than
outlying
being
wards.
an outlying ward, okay.
And so that makes we also kind of that's in terms of saving money. But I think the most important thing from sort of my personal perspective was how it totally changed our relationship to the patients. It totally changed our relationship as a team, and it was the proudest thing I've ever been involved in. In terms of all of it, and again, I sort of say, I started off my sort of neurology career doing the fanciest MRI scanners, going around the world talking about it. But I ended up getting more excited about the consistency of a comfort feed on somebody who was dying from a stroke, and I kind of tell you now which one I think is more valuable. So in terms of an offer of hope, so here we have, so this is the 5-year forward view, which I try not to mock too much. But this was an analysis done by KPMG about, do people really think that the 5-year forward view is going to help? And it says, no. But in the middle of the analysis, there is this. What do you regard as the most valuable incentive for change? The opportunity to improve care for patients. It's totally clear to me. Everybody is invested in doing this. It's just how do you do it? And I promise you, this method will work. So this is my hospital, where I've done the analysis across all of the departments. Anything with a red box, there's a 50% productivity gain from doing the same analysis. This was when PCTs existed. This is the programme budgeting report, where I've got all of the conditions, anything with the, I haven't looked at all of them, but I've looked at those, anything with the red circle around it, it's got a 50% productivity gain. So the way going back to those 7 characteristics, the improvement method does exist. And when you kind of use it, it's fantastic. It really binds, everybody together. And I definitely developed it from the kind of the vanguard thinking. and I, encourage using it. My only word of warning would be that in 2008, 2003 to 2008, it was a much more permissive context. So I could experiment much better. 2009 to 10, when I did this stroke stuff, I was able to use the work I'd done to get a mandate, but it was bloody hard work, keeping the top-down influence. From beyond 2011, I found it was impossible to get a project at scale, to get the top-down interventions so pervasive. It's very difficult to get the space to do it on a big piece of work. But in local teams, you can still get going. So I'll stop there and I'll take some questions.
Are you concerned about that the changes up to 2011 that kind of prevented you going in and carrying out this kind of work?
Am I worried?
Yeah.
I mean, they just, yeah, of course. And I just don't know how to break them. I mean, the problem is, well, I kind of now know the theory, kind of why that happened. So when you kind of think about, the whole idea, when I'm sort of there on my course and Jeremy Hunt's talking to me, I'm looking at him thinking, what is it you bring to this dynamic that helps me? What pearls of wisdom do you have flitting around that little brain of yours that are of any use to me trying to do this? None. And it'd be the same for Simon Stevens. It'd be the same for David Bennett Monitor or for David Flory. But I look around the room, everyone's looking at them like they're kind of demigods. And I don't know how, at the moment, I don't know how you break that.
I was going to say, have you got any advice for, because I found today completely fascinating, and I'm now buzzing with ideas and things that I want to go and try and put into practice, but I also feel slightly overwhelmed by the thought that me as an individual, and even if there's a few of us that group together, that we could only go so far, because eventually we'd get stopped by someone saying, well, no, but that's not how it works.
Yeah, I think, so I'm a very optimistic, proactive person. It's really kind of, whoa, this is a difficult challenge. This is hard, trying to find a way around this. I guess what I would say is time moves forward. Something catastrophic is going to happen, probably this winter. There will have to be some review. So in terms of what I would do, what my advice is, so just think really strategically. You've got to do all your preparation work before you get to business planning. So get your data together. June, July. Then you have to smile sweetly through business planning, where they're going to go, we're doing our cost improvement plans here. So then that gives you, because they're all distracted by that, that then gives you from like April through to August to do something. And then try and get it done. And then August comes in, oh my God, the quarter three figures are in, the month three figures are in, we're going to have to tighten down and not spend any, paper clips or anything. So that's how I did it. You just get strategic, just kind of use windows of opportunity. And you just, and that it does make it more palatable to kind of sit in those ridiculous meetings.
I just wanted to ask about the actual operational side of it.
Yeah.
The measure that measures patient satisfaction.
Yeah.
How did you gather that, or what did you do to get that?
Well, I suppose to begin with, it was like, can we not get a complaint, please? But actually, one of the other things I found was so at that time it was the National Stroke Strategy, so they were kind of giving us some money. And interestingly, social service came to me and said, "Oh, we've been given some money for stroke as well. What should we do?" I said, "I tell you what I want you to do is it was only about £20,000. I said, look, go and find out in our community what services exist already for stroke." And she came back and said, "You wouldn't believe how many." And we found charities that we're trying to get onto the ward for aphasia, for diabetes, for all kinds. So, in terms of study, so in the afternoon on our walk, we had this like band of people from charities who were able to adapt, able to kind of interface with the different patients. So again, you know, so in terms of measuring that, I mean, we had our, I can't remember what it was, but I was trying to think what the official one was at the time. I don't think there was one at the time. But what we did, so we developed like this 12 measures. But you don't want to have too many. So you want to kind of, so we started with 8, and then the team themselves started adding in 1. But we would only add 1 when we were totally happy with nailed the other ones, and patient satisfaction was 1. We would start something like number 11. But you'll find, and the patient satisfaction for these patients is how do you start measuring? We've given your mum a good death. That's kind of what you wanted to get into. But then you have to be quite strategic because while it all sounds right now, the idea of interfacing people who are dying can cause a surprising amount of antibodies. And what happened during this was the Liverpool care pathway got pulled away, which we could see was terrible because we were using it all the time. We could see how you could easily misuse it now we really understood it. But you'll find that once you get into it, there's millions of ways you can think of doing it well.
I was interested when you sort of earlier in the presentation, looking at the kind of the value, your diagram there,
Yeah.
the kind of administrative support and the clinical part, and how
Okay. Yeah.
looking at that. I have quite a good example that I got involved in a new job, which was halfway through somebody else's idea, where we looked at putting. I work for community services.
Yeah.
And we were looking at hubs where we had co-located services, and somebody had come up with this bright idea to have an admin review, which in principle the idea was fairly sound. I'm not quite sure where they came across the idea of how many admin staff they need, but it is moving forward. Now looking at this thing, well, clearly we've got enough. I've had one of my team leads, funny enough from the community neuro rehab team, actually do archiving because they can't get stuff in the file because of all the few admin they have got doing something else. So we're having to sort of go back really to the beginning and say, we've tried this out, it's clearly been quite detrimental to some of our services because we've got very well qualified and experienced clinicians doing admin tasks that we should be having an administrative person doing. But it's coming from it the wrong way around, really. But this is why this is really quite useful in using this value framework. Because I'm doing a business case as part of our next year's business planning, saying, okay, we clearly need to address this because it's just really inefficient.
Yeah, no, I mean, it's really difficult, so in terms of kind of sort of the conceptual underpinnings of this. So it's like, so why should that? So you hear a lot of this term, quality is free. So if it's higher quality, it'll be cheaper. But if you go and read the book of the guy who wrote that, he sort of said, no, what that means is to begin with, you costed the design. What they mean by it is, so when you were designing that car, you worked out, if you did it right, it cost £4,000. You could sell it for £5,000. Every time you screw up delivery of the design, and it costs you a bit to fix it, you're eating into your profit. But of course, that assumes that you've got a design and an underlying cost, which we haven't in health. So it's a big leap of faith. But the leap of faith holds true because the more complicated the process is, and healthcare is unbelievably complicated, the longer it's been undesigned, and healthcare has never been designed, so you've got like 60 years to have a go at, the higher the chance of finding massive opportunity. But that's the leap of faith.
I think it's also that, I think you alluded to it earlier, it's doing things in isolation, not understanding or necessarily being able to predict the unintended consequence and the knock-on effect on other parts of the system.
Yeah, totally. I mean,
I kept at the time, I kept thinking of Jenga, you pull out this one, and at some stage you pull too many out and you're not very looking at what you're doing, the whole thing falls over.
Yeah. But I mean, I saw this, so one of the things, my crazy journey was kind of, I was looking at waiting lists across the whole pathway. So at the time, no one was measuring follow-up waiting lists. So demand in was unbelievably stable. And actually the waiting lists for the first 3 steps, diagnosis, treatment, so the first assessment, diagnostics and treatment were pretty stable. But follow-up was just going up and up and up. And for the clinicians, that's where all the clinical risk was. And the middle managers, the managers couldn't understand why the consultants weren't playing ball, because they were, it's like, do you not get it? You know, when I'm in a clinic, the new people are easy, the hard ones are the complicated people on my follow-up list. And you're making them wait. In fact, you're taking them off my list and putting a new one on without telling me. Do you not understand that?
Yeah, I mean, the 18 weeks had a knock-on effect that for a community cardiology service that we used to manage. And you were looking at that all the time saying, come on, we've got to see if we can get these people through. And what you didn't, you took your eye off the ball for the follow-ups later on, so people were getting diagnostics through, and then there was a huge long wait for the follow-ups because they were trying to meet the 18 weeks for the first bit, and it just screwed the whole thing up.
Well, and of course, the important thing is, and it's all to do with who's in your frontline staff. So if they were like, I don't know, they were cleaners, you might get away with that. But you're not going to get away with it when they're your most intelligent workforce, right? You know, and that's where this disconnect is happening, and that's what worries me most at the moment. I can see that the most proactive go-getting people, they're the ones that are leaving, and they're kind of leaving because you can only hit your head against the brick wall for so long.
With that particular instance, it was a very, very small service with one. We worked very closely with a consultant at the acute, but it was one GP with special interest, and she unfortunately fell off her bicycle and was out of action for quite a while. And suddenly, I'm a clinician, I'm thinking, oh God, all these people, we sorted it out, but it was a very fragile service. And with all these diagnostics were coming in, and the administrators were thinking, oh my God, what do we do with this? We had people help us out, but it was just a real good example of
Can I ask you, in terms of sort of your current resources, I mean, obviously you're working clinically, how do you find the time to do this within balancing sort of work? And secondly, are there any lessons thinking about how you encourage the workforce who are feeling completely drowned by the workload to be able to start thinking and being able to apply some of this?
Cool. Now that is very difficult. I mean, that really is difficult. I mean, and the reason I say that was on Friday, it was a whole day I was talking at a conference, and I kind of left it feeling quite drained because I'm not sure how to answer that question. It's now I really do understand. I talked about those 7 characteristics, and each of those 7 characteristics are really quite interesting issue. How to lead, how to manage, how to do frontline leadership. And the thing that worries me most is that to get the skills that we need at scale, you can't do it overnight. And I just can't at the moment see enough of a gap in the system that will allow it to flourish. So what I say to people is just try and find your own sphere of influence and start having a go. I don't know whether that's going to work. I don't know whether that will be enough. Probably more than half of me thinks the whole thing's just going to crash. I think actually it'd be better if it did crash. Then the politicians would have to do something less. I suppose when I was at Harvard, one of the things that they did was like this analysis of international reviews of health services. And what's most tragic is every other developed country has done a proper strategic review and has a proper 10-year plan, which has got this in it. And there we are with a bloody Health and Social Act, where you've got a bunch of laws that everybody is desperately avoiding, worrying whether the lawyers are going to, and then you've got the 5-year forward review, which is 38 pages, which should just be thrown away. So I don't know, I haven't answered your question very well, I might say.
But how do you do it personally?
Yeah, well, so I can tell you my sort of personal. So up until 2008, it made me ill. So then I thought, okay, but I still was passionate about it. So then I kind of took a bit of time to clarify my thinking, manage and lead in a more sustainable way. Then I've tried to re-engage. Obviously, doing this fast-track course up until April this year was like my routine. But I decided no. So, and in many ways, I'm kind of backing away from the system. I just can't see a
So that was a
sustainable
fast track into NHS management.
to be chief executive. But I was looking at it thinking they're all bloody mad. And and I suppose my first experience of it is you try through willpower and overworking, but that just isn't sustainable. Which I kind of learned the hard way. So now, when I'm only looking at it again, you just got to. But again, I suppose what I can say, and what in a more optimistic, hopeful way, is somehow always something emerges. So at the moment, I'm kind of thinking, oh my God, it's difficult. But I suppose when I think back to previous moments like this, out of left field, some opportunity will kind of emerge. And I guess I suppose the most important thing to say is that this, you can't. What's happening to the NHS is a microcosm of everything else. So there is no hiding place, really. And I don't want to end up work in a health service that is, when we was part of my course, I went to South Africa and saw a private public system that was just horrific. And I don't kind of want to be part of letting that happen. But I honestly don't really know how to avoid it at the moment. But I do trust somehow a Martian from outer space is going to intervene or something.
It is easy, isn't it, to I'm Zoe Nicholson, I'm the Chief Executive of Brighton and Hove's Creative Care Service, and I also sometimes feel that the rest of the system is so not designed to support the intervention that we all know are really just common sense. And so much today I've been reminded of how simple it is in so many ways to do the right thing, but how so often the system is designed in a way that really doesn't support us. And it's easy to kind of go, oh God, the rest of it's just never, ever going to change. And I always think that the only real solution to that is to identify what can we do that's really small. We take a small step. We take a small step, together. That really makes a change, and that's always been a bit of our sort of guiding principle. And sometimes when you have that kind of attitude of let's just take what is the smallest step you can take, then something left field does occur.
Yeah.
A sort of doorway opens up like, oh, that's quite interesting. Should we go and have a play in there?
I think that's it. Yeah, and I would say yes, I totally agree with that. And what I would also add to that, when I think back, is sense where you feel energy and move towards that. That's the other thing, and that sounds very kind of new age, but I found increasingly, so it's funny, this is the fourth group, and there's been a different energy with each group that's come. Some I've moved more towards than others, So again, you could just use that, and so again, on Friday I left it totally exhausted, and I kind of realised that a lot of that was so many of the interactions just were energy sapping, but I thought a couple of them actually were really energising. So if I just gravitate towards that more, and I think that's all we can do.
I completely agree with that, Zoe. I do think we're in danger of trying to do too many things at the same time, so we never actually achieve anything.
Yeah.
We're just all running around achieving anything. It's terrible.
I think your earlier slide where you identified the biggest area that is impacting, is a very good place to start. It's an area where possibly even fairly small change because it's very high volume, high intensity.
I think that was so. And the other kind of realization I've had is so Toyota, when they say they talk about what they do, you can only change one thing at a time. And they say if it doesn't have a big impact in about 3 or 4 days, you've picked the wrong thing. And so I've kind of slowly got into my head, oh, okay, so change, when you think about it, you can only change one thing at a time. So you've got to try and find really strategic, individual interactions. And again, when you kind of, I found this like with my own team, when we kind of look back at our 10-year improvement, we actually only changed really 5 things. But to change 5 things and to change everything around them was really difficult. So just moving onto the ward, instead of having 6 individual ward rounds to 1 doctor on the ward for a week, to make that one change happen, we had to change the timetables and job plans of everybody for all their outpatients and everything. But when we tested it, it halved the length of stay and made it a much better experience for all of us immediately. And so that's another part of this. It's like, you can really only change one thing. You've got to try and find the right thing, and that's it. And if it doesn't change quickly, you've probably got the wrong thing.
If you change multiple things, you don't know which is the beneficial channel.
Yeah, well, I think it seems to be throwing mud at the wall. It doesn't really work. But there's a lot of mud throwing going on. So I think we're out of time, guys.
Thank you.
Cheers.